G'day everyone, Stuart Hinds here. Doing something different this time. Opposed to just doing treatments on muscles and trigger points, I'm actually going to run you through a bit of a case study. And this is, for me, I suppose, for most therapists out there, this type of condition really goes under the radar. And unless you're actually looking for it, you probably won't be aware of it. So what I'm talking about is peripheral nerve entrapment. So this is Seb, and he's got a classic peripheral nerve entrapment. Seb here is a diligent jiu-jitsu practitioner. He's a rock climber. He does weightlifting. He does everything. He just happens to be my son as well. So he's volunteered his services for today. So Seb came in about 2 days ago to the clinic and was complaining of sort of neck, shoulder, bicep, forearm sort of type symptoms. So when you get someone coming in like that, the problem is if it's a peripheral nerve entrapment, what you'll find is most of your clients will have trouble telling you exactly where their pain is. Okay, I get a little bit in my forearm, I get some in my shoulder, sometimes it goes to my bicep, sometimes I feel it in the back of my shoulder, and my neck is really stiff. So for a lot of practitioners, you will get quite confused in terms of, is it shoulder, is it a neck pathology, is it a forearm, is it an elbow issue? A lot of the times, if it's poorly localized and they're chasing the symptoms and they're not sure exactly where it is, or you can't reproduce their pains, you'll be looking at a peripheral nerve entrapment. So a peripheral nerve entrapment is different to a nerve root problem that refers pain down the arm. So that's a radiculopathy. So that is really nasty pain. These symptoms are so much more subtle. So for Seb, obviously when he's loading up doing rock climbing or jiu-jitsu or whatever the case may be, he may get pain at different areas. So really depending on your clients, where they're going to feel it. So it might be their neck, it might be their shoulder, it might be obviously their forearm, or it could even go as far as their wrist as well. So first thing that I'm going to do here is basically isolate the neck and any dysfunction there. So the first thing that I do straight away is assess the neck. And the first place that I'm going is I'm going to put my hands right over his scalene. Now for Seb, his left hand scalene is popping right out at me as opposed to his right. The way that I'll know how tight they are is I'll get him to go into rotation. So turn your head to the right and I can feel his scalene is popping right out. Okay, so it's pushing my finger out. All right, come back around to the left, Seb. So whereas the left sort of sits back. So I know that straight away. I'll also know by the height of his first rib too. So he's a little bit higher on that first rib than he is the second. So I've already treated Seb 2 days ago. We've got some awesome results so far. So today is more about a bit of a cleanup. So with these neural problems, you'll probably find they're unlike muscle problems, okay, where you treat muscles and all of a sudden the function becomes basically restored straight away if you do it right. Nerve situations are different, so there's a lag time with them. So you've got to allow at least a week for the symptoms to subside, then you cascade by doing another treatment and then another one and another one. But Seb's also doing some neuromobilization stretches that I've got him to do. So he's got a bit of a median nerve entrapment, but he's also got a radial nerve entrapment as well. So I'm going to take you through the assessment. So first protocol is neck, okay? The second one will be, I'm going to look at his shoulder as well. And why his shoulder is important is because of the stuff that he does. He does a lot of manual labor as well as weightlifting, and he's also doing the jiu-jitsu and he's doing rock climbing. So he's doing a lot with his shoulder and he's asking a lot of his shoulder as well. So I've got to rule out whether or not the shoulder's actually moving well. First thing that I do is get right onto the top of his humerus, almost in that subacromial space. I'm just going to drop my finger in there, sort of in the anterolateral, almost where the supraspinatus sits. So what I'm going to do is take him up into abduction. Now, what I'm looking for is what is his humeral head doing, okay? So if it's starting to rise up as I go up past 90 degrees, then I know he's going to have an issue with this teres minor and that subscap, because their role, especially the subscap, is to help depress the humeral head as it comes up. And if that's not doing its job, then it'll push up. So that's when you start to see these impingement signs. So with Seb, obviously we don't have that issue. it's feeling good, it's dropping back down, so we're not getting that issue. And he's obviously not getting any catching pain or uncomfortability in that anterolateral space. So that's really important. I also want to have a feel of what his pec minor is like as well, because that's also going to be part of the process of unwinding these peripheral nerve entrapments. So obviously just feeling from one side to the other, yep, you can palpate it, but I've also got a little assessment tool that I've developed over the years, and that's right. Find the coracoid process where the pec minor comes off. We've got the corcobrachialis and the short head of biceps, all attaching onto that little bony prominence. So what I do, finger goes right onto the attachment there, and then I just drag the shoulder back into extension. And what I'm feeling for is the first point of pull onto that coracoid process. So I'm getting it about here, and that's when I'm feeling it. If someone's really super tight in this, you'll probably get to about here. You won't even get to neutral, and you'll feel it pulling. And that's an issue straight away. So that's obviously going to be the second point. So in terms of entrapment sites, yes, neck, obviously the scalene first rib situation, then obviously rule out the shoulder, pec minor. And then once we've cleared those, then we can start to wind up the nerve on a stretch. And then we basically just treat wherever we find it. And I'll run you through that process as we do it. So we're going to split this case study up a little bit into about 5 different videos just so that you can. So I've done the assessment. I know where his first rib is a bit high. I know his scalenes is quite hypertonic. I know there's a bit of tightness in that pec minor. I know the shoulder's moving all right, so I won't actually have to address that today. But now I need to wind up his nerves and see where he's feeling it and see how much range of movement he's got. So, Seb, let's get you to lie on your back. So I can't take credit for this, these nerve mobilisations. This was developed a long, long time ago by a physio over in Adelaide, actually, Dr. David Butler. He put a text out. It was called Mobilisation of the Nervous System. Incredible read. Very heavy on neuroanatomy, so if you can digest that, it's a pretty good read. But basically, it's all about putting your clients into these nerve stretches, if you like, or mobilizations, and assessing where their neural range of movement is. So we're going to do the median nerve first. So how we do that is clients lying on their back, they need to put their head into lateral flexion. Okay, so it's really important that they stay there. We come over the top with our elbow and we're going to depress the shoulder down. And then I'm going to take the arm up to about 90 degrees shoulder abduction, a little bit of external rotation, wrist extension, and then we wind them out from there. Seb, you just tell me when you start to feel it. So he's feeling it about there. Where are you feeling it, mate?
In the bicep.
Okay, so you're feeling it through that area?
Yeah.
Okay, so we know that we can't get to full range of movement. Full range of movement, you're dropping him right back down here. I'm not going to do that to him now because I'll wind him right up. But we know that's where he's feeling it through there. We're also going to test what his radial nerve is like. So same position, all right. We're going to basically bring the shoulder down, extend the wrist, okay, and then I'm going to bring him out to abduction. Just tell me when you start to feel it, Seb.
Yeah, there.
About there. Whereabouts are you feeling that?
Forearm and hand.
Forearm and hand, right. Bring your head back to neutral again. How does that feel when you come back? Yep, okay. So one of the things you need to do is move their head in and out of lateral flexion. Why that's important is if we've got him on the stretch, got him on a stretch this way, we move the head back and he's still feeling that tension, then that's predominantly just more muscle as opposed to nerve. So we put the head back into lateral flexion and winds it back up again, then we know we're dealing with neural tension. Righto, so they're my go-tos. So now I know how much neural tension he's got. I know where he's feeling it. I can go clear the neck first, clear this here as well. If he had a shoulder issue, I would clear that as well. So I know that I've set all the entrapment sites and offloaded those, and then all I have to deal with is wherever he feels it down through here. Okay, so really important, especially when they're in this position, coming in and your palpation. So if you find there's the clavicle here, we roll off it, push the traps out of the way, push down, and we will be on his first rib. If I come in behind his scalene, behind his SCM. Then I'll find his anterior scalenes, his medius, and then his posterior there. And I'll walk you through the treatment process for that in the next video.